Assalamu alaikum wa rahmatullahi wa barakatuh. Today our lecture is about the management of urinary retention in pregnancy, postpartum, and after gynecological surgery. The objectives: first, to maintain bladder function and to provide appropriate management to women with postpartum voiding dysfunction. Second, to minimize the risk of prolonged voiding dysfunction in the puerperium. And third, lastly, to prevent the long-term sequelae. Introduction. Postpartum voiding dysfunction is defined as failure to pass urine spontaneously within 6 hours of vaginal delivery or following catheter removal after delivery. This occurs in around 0.7 to 4% of deliveries. Hormonal changes in pregnancy decrease the tone of the tracer muscle, combined with the trauma to the bladder, pelvic floor muscle, and nerves during delivery, and the postpartum bladder tend to become underactive and therefore vulnerable to retention of urine. So several factors that lead to retention of urine. First of all, hormonal changes in pregnancy. As we all know, progesterone lead to reduce tetracycle muscle tone, so urine will stagnate in the bladder. And in addition to the trauma that can happen during delivery or cesarean section, which can affect the pelvic floor and nerve. So, urinary retention, UR, is inability to empty the bladder normally. It's called overt if it's acute. Occur when there is a sudden inability to spontaneously void. Covert urinary retention occur when women pass a small amount of urine and has an elevated post-void residual urine volume greater than 150 ml with no symptom of urinary retention. So, urinary retention can be divided into overt and covert. Overt, which is acute, that the patient or the mother cannot be able to void spontaneously, while the covert is has no symptom, but there is residual volume more than 150. Persistent postpartum urinary retention is inability to void spontaneously by the third day of postpartum, despite the use of intermittent catheterization. So what are the risk factors for urine retention, either during a pregnancy or postpartum or gynecology? So the causes during pregnancy, if there is uterine fibroid or congenital uterine anomaly or pelvic adhesion or retroverted uterus or pre-existing voiding difficulty. These are the factors during pregnancy. Postpartum, due to inhabit in nulliparous, prolonged labor, second stage, assisted instrumental delivery, excessive perineal injury, mediolateral episiotomy, neuraxial anesthesia, baby weight more than 4 kilogram, cesarean section, shoulder dystocia, previous history of urinary retention, manual removal of placenta, postoperative immobility and wound pain, constipation, English not first language communication barrier. What are the gynecological causes? Posterior anterior surgery, hysterectomy, midurethral sling, TOT-DVT, laparoscopy, intravesical injection of Botox, infertility investigation like hysterosalpingogram or hysteroscope, laparotomy, other pelvic surgery, previous history of urinary retention, post-operative immobility and wound pain, and also constipation. English also not the first language communication barrier. So the causes either during a pregnancy, any mass, or adhesion, or retroverted uterus. or if she has a previous history of similar condition. Postpartum happen mostly in primary gravitas, or prolonged labor, or instrumental, or using epidural anesthesia, or manual removal of placenta, and gynecological causes as mentioned here. So if postpartum voiding dysfunction is unrecognized, it can lead to long-term sequelae such as recurrent urinary tract infection, urinary incontinence. So prevention of this should aim to identify all women who are unable to pass urine within 6 hours of delivery or catheter removal, and all women who are symptomatic of voiding dysfunction. The importance of prompt diagnosis and appropriate management of these women cannot be overemphasized, as early intervention is the key to ensuring rapid return to normal bladder function. So, what are the postpartum bladder care? Consider reinserting an indwelling urinary catheter in women after regional anesthesia and prolonged labor, mid-cavity instrumental delivery, urethral trauma, severe perineal trauma, women receiving high dependency care, for all delivery and procedure in theater who have spinal anesthesia, including confined spinal epidural or have had epidural anesthesia topped up. So here is important to catheterize these women postpartum. So again, the risk factor for postpartum voiding dysfunction is the same as we mentioned previously: primary gravita, instrumental, epidural, anesthesia, prolonged labor, perineal trauma, especially urethral injury, or nearby history of voiding problem. But sometimes postpartum voiding dysfunction can occur without this reason, means without any cause or risk factor. So here we have to consider insertion of indwelling urinary catheter. Again, here, what are the intrapartum event contribute to bladder dysfunction? This is study done. They found that the risk for episiotomy hematoma, prolonged second stage, obstructed labor, precipitate labor, atonic postpartum hemorrhage, eclampsia, deep transfer arrest. All these are risk factors for intrapartum event for bladder dysfunction. So intrapartum bladder care, we mentioned about postpartum bladder care. What are the intrapartum bladder care? The prevention of postpartum voiding dysfunction starts with good bladder management intrapartum. So one of the important factor to avoid postpartum voiding dysfunction is management of intrapartum. And this includes documentation of the frequency and volume of bladder empty. Women should be encouraged to empty their bladder every 4-6 hours. If the woman is unable to pass urine spontaneously, we will use intermittent catheterization. And ideally, this to be done at time of vaginal examination. Some patients, especially primary, will examine them every 4 hours. We can, in that time, use intermittent catheterization if the patient couldn't pass urine spontaneously. If catheterization is likely to be used more than twice, so better to put indwelling catheter. An indwelling catheter should be removed during an active second stage of labor and assist vaginal delivery to prevent trauma to bladder and urethra. We mentioned this slide. So again, what are bladder management following cesarean section or vaginal delivery or using of epidural? With epidural, the number of cesarean section, as you all notice, that is increasing. Approximately 1 in 4 women will have cesarean section. So bladder sensation will take 10 hours to return after cesarean section, and spinal analgesia, and over 6 hours following vaginal delivery, with or without epidural retention of urine. Following cesarean section does occur, even though women will have been catheterized for 12 to 24 hours after delivery. Women most at risk are those who have undergone emergency cesarean section for lack of progress in labor. So here there is postnatal bladder care flowchart in one hospital. Is that first of all, they will ask about first void delivery, post-delivery should be routinely measured and recorded. Direct questioning from midwife to patient about their voiding pattern. Postpartum urinary retention should be suspected if no voided more than 6 hours, and passing frequent small amount of, and still she feel that of incomplete voiding. So postpartum urinary retention should be suspected, offered or covered. Offered that she is unable to void within 6 hours. Covered, she able to pass post feeling incomplete voiding. Here we'll insert catheter to see the urinary retention or how much amount of bladder volume, or we can do bladder scan. So if the urine or bladder volume less than 500, measure the next voided volume and post-volume residual, post-voiding residual volume. If less than 140 or less than 20% of voided volume, no further management required. But if the urine bladder volume more than 500, insert urine catheter for 1 to 2 days and attempt for trial without catheter. And reassess record second void. If more than 150, again milliliter, again it means the second time, more than 150, we will recatheterize for 1 week and refer to the urogyne. We will discuss this more in another chart from RCBI of gynae. So here, management of urinary retention. Measure first 2 voids post-delivery or surgery or catheter removal. So if no urine passed within 4 hours post-delivery or surgery or following removal of urinary catheter, we will do abdominal examination to see if there is any bladder, you feel the bladder is full. Check perineum to see if there's any injury or any trauma, any hematoma. And we'll go for conservative measurement. We will advise for disposable cold bag, ensure adequate pain relief, apply conservative measure. And commence intake output chart. Encourage regular fluid intake and void within 2 hours. If second void 200 ml with normal sensation, no further action required. So this is the first thing, is we will measure the first 2 void. If she is unable to void within 4 hours, we'll go for conservative measure and encourage regular intake and void within 2 hours. If second void 200 ml with normal sensation, so no further action. But if no further within 6 hours, here we say 4 hours. Give her another 2 hours. So if not able to void after 6 hours, so we'll do bladder scan to confirm retention and insert urinary catheter and ensure adequate drainage up to 10 minutes. So if passing small amount less than 200 ml or symptom of voiding dysfunction or no void within 6 hours after conservative management, in this case, we will do abdominal examination as we say here, and no void within 6 hours or void more than, no void within 6 hours, we'll do bladder scan and insert urinary catheter to ensuring adequate drainage for up to 10 minutes, and clinical risk form. So if residual volume less than 150 ml, remove catheter, continue conservative measure until to void more than 200 ml. But if residual volume more than 150 and 500 ml drained, catheterization should be kept for 1 day. If more than 500 ml to less than 1,000, we will keep the catheter for 2 days. But if the urine retention more than 1,000, we will keep for 3 to 5 days on continuous drainage. Of course, during this time, we will send urine sample to rule out a UTI, and we'll start with trial without catheter from 6 a.m., encourage mobility, and for hourly void, complete intake, output chart, include abnormal bladder sensation, inform senior obstetrician, bladder care nurse, midwife, or physiotherapist. If unable to void more than 200 ml with normal bladder sensation on second occasion and residual less than 150, no further action. If women report incomplete emptying or reduced bladder sensation, check residual volume within 5 minutes of voiding. If less than 150, reassure the woman and advise on bladder care. Later, we'll explain what's bladder care. But if unable to pass small amount, unable to pass or passing small amount less than 200 and residual more than 150, we will teach her about self catheterization. If women reluctant or unable to repeat catheterization, followed by trial without catheterization until voiding more than 200 ml and residual less than 150 ml. Follow up an outpatient appointment to be made with obstetrician within 2 weeks. Self-indulgent catheterization to cease when residual volume are less than 150 ml on 2 occasions. Refer women with ongoing voiding dysfunction to urologist, gynaecology. So again, we'll repeat this chart because it's very important. As we mentioned that urinary retention is 2 types, either overt or covered. And we must treat it as soon as possible to avoid bladder injury. So we will measure to void post-delivery. If no urine passed within 4 hours, we say that urine retention more than 6 hours, but after 4 hours, there's no urine pass, we will go for abdominal examination and conservative management and increase fluid intake. And then we'll ask her to void within 2 hours. So it will be 6 hours. If no void at all, so we will go to the this line of treatment. But if to void 200 ml with normal sensation, no further action will be required. So, for example, if the patient complain of abdominal pain, I will examine her. We'll see that full of bladder. We'll ask her to void, and if she is unable, and so we'll go to second line of this chart. But if she is able to void and the void is more than 200 ml with normal sensation, so no further action required. But if passing a small amount, less than 200, or unable to void, so here we'll put insert urinary catheter up to 10 minutes, and we will measure it. If less than 150 residual volume, remove catheter and continue conservative measurement. But if residual volume more than 150 but less than 500, we'll keep it 1 day. If more than 500, less than 1,000, keep it 2 days. If more than 1,000, we'll keep it for at least 5 days. Of course, during this time, we'll send urine sample for catheterization, and then we'll try without catheterization in the morning. If she is able to pass more than 200, reassure her. If the women report incomplete emptying of bladder and residual volume less than 150, also reassure her. If unable to pass urine or passing less than 200 or residual more than 150 ml, we will teach her self-indulgent catheterization. And if she is reluctant or unable to repeat indulgent catheterization, followed by trial without catheterization until voiding more than 200 and residual 150 ml. So the aim is that if she able to pass urine more than 200, reassure her, and the residual less than 150. And of course, we'll give her appointment after 2 weeks with urologist, urogynecologist, and with obstetrician. So here's are some points that we'll advise the women with urine retention. First of all, we'll tell her that it's normal to empty your bladder approximately every 3 hours during the day. The best position to sit on toilet seat and do not hover above it. Use a footstool as you see here in this picture, or raise your heel so that your knee are higher than the hip. Lean forward with your feet apart and your elbow on your knee. Similar to this picture, allow your tummy to relax and do some gentle, deep breath to help the pelvic floor relax. Allow yourself time. Do not rush or strain to empty bladder. Using the position can make it easier to empty the bowel. So any woman with urine retention, we will advise her to sit in this position in order to help empty the bladder. Again, use stool to elevate food. The knee will be higher than the hip, and lean forward and the elbow on the knee. And do some exercise to relax pelvic muscle, and do not strain. Also, we'll ask her double bladder emptying. So what is double bladder emptying? We'll tell her if you feel your bladder has not completely empty full, rock your pelvis backward and forward on the toilet seat and try again. If not successful, stand up, rock your pelvis backward and back forward, then sit down and try again. Again, we will ask her some conservative management to urinate in warm shower or bath. Running water in the background can help to empty your bladder. Place your hand in cold water as you empty your bladder. Firmly tap over the bladder with your finger. Whistling gently to put some pressure on the bladder can help. Ask your midwife or doctor for pain medication if pain is stopping you from emptying your bladder. Also, advice for pelvic floor muscle exercise. So pelvic floor muscle exercises are very important for healthy bladder function. The physiotherapist will teach you and advise you how to do it and how to do start pelvic floor muscle exercise, reduce swelling and pain. During your pelvic floor muscle exercise, lying down and very gently can help with healing, reducing pain and swelling. Try to rest lying down as much as possible to reduce the effect of gravity on the swelling in your pelvic floor. You can use disposable cool packs over your underwear to help reducing pain and swelling. But held firmly against your pelvic floor by supportive underwear can also help. And these are the references that I used for urine retention. Thank you for your listening.